Okay guys, starting with the next thing which is called as, right, we'll start with this topic called as retina. This is a new topic, retina. So guys, remember retina. Retina is what layer of the eyeball? What layer? Retina is the innermost layer of the eyeball. The most important layer in the eye is retina. Retina and cornea both are very important, guys. Retina is the innermost layer of the eyeball, right? Now what we need to remember about this retina is, this retina is made up of 10 layers. Retina is made up of how many layers, guys? It is made up of 10 layers. The first 9 layers are the neurosensory layer, and the 10th layer of the retina is called as retinal pigmentary epithelium. Retinal pigmentary epithelium, right? The first 9 layers are the neurosensory layer, and one layer is the retinal pigmentary epithelium, right? There is inner limiting membrane. There is a mnemonic, guys, to remember the layer's name. There is a mnemonic. Okay? The mnemonic is, in new generation, it is only ophthalmologist examining patient's retina. In new generation, it is only ophthalmologist examining patient's retina. In, I stands for what? The inner limiting layer. New generation, N stands for the nerve fiber layer. The 8th layer is the ganglion cell layer. Generation is ganglion cell layer. This is the most important. If you don't remember the all layers, all it's fine. But you have to remember this layer. The ganglion cell layer. Why you have to remember? Why? Because this is the most radio-resistant layer of the eye. It's the most radio-resistant layer of the eye. Then comes the plexiform layers. Okay? So, it is inner plexiform layer, then outer plexiform layer, then it is outer nuclear layer, and next is its inner plexiform layer, then there is inner nuclear layer, then there is outer plexiform layer, then there is outer nuclear layer. Okay? Inner plexiform layer, inner nuclear layer, outer plexiform layer, outer nuclear layer. Okay? Next is what? Examining means external limiting membrane. Next, the photoreceptor layer, where rods and cones are there, it receives the light impulses. And the last is what? The retinal pigmentary epithelium. Whenever we use any laser in the eye, it usually acts on the retinal pigmentary epithelium. So guys, if you don't have to remember all the layers, but you have to remember which is the most radio resistant layer in the eye. It is ganglion cell layer. And which is the layer which is commonly affected by lasers and all? It is a retinal pigmentary epithelium. Now, why are we discussing the layers of the eye? Why? Because there is a condition called as retinal detachment. There is a condition called as retinal detachment. So, imagine guys, these are the layers 1, 2, 3, 4, 5, 6, 7, 8, 9, and this is what, guys? 10. Retinal pigmentary epithelium. The first 9 are the neurosensory layers, and the last is retinal pigmentary epithelium. There is a condition called as retinal detachment. Retinal detachment meaning what? The detachment between the neurosensory layer and the retinal pigmentary epithelium, right? When there is a detachment between the neurosensory and the retinal pigmentary epithelium, that is called as retinal detachment. Do you see the space over here? This is retinal detachment. Yani the detachment between the neurosensory layer and the retinal pigmentary epithelium is called as retinal detachment. Okay? Sometimes the patient might have detachment in between the neurosensory layers. The detachment in between the neurosensory layers is called as retinoschisis. The detachment in between the neurosensory layer is called as what, guys? Retinoschisis. One is retinal detachment, other is retinoschisis. Retinal detachment means what? The detachment between the neurosensory layer and the retinal pigmentary epithelium is called as retinal detachment. But the detachment in between the neurosensory layers is called as retinoschisis. Retinoschisis. Okay. Now, retina is having 10 layers, whereas the fovea and macula, they have 4 to 5 layers. The fovea and macula, they have 4 to 5 layers. Once again, what is retinoschisis? The detachment in between the neurosensory layers is called as retinoschisis. Whereas what is retinal detachment? The detachment, what is retinal detachment, guys? Retinal detachment is the detachment of retinal pigmentary epithelium from the neurosensory layers. From the neurosensory layers is called as retinal detachment. It's called as what, guys? Retinal detachment, right? Now, we are discussing about what? We are discussing about retinal detachment. What is the complaint of the patient when the retina gets detached? Okay? What is the complaint of the patient when the retina gets detached? Whenever there is the retinal detachment seen, imagine this is the cornea, guys, this is the retina. Whenever there is retina getting detached, what is the complaint of the patient? Patient complains of floaters, which are also called as muscae volitans. Patient complains of what, guys? Floaters, which are called as muscae volitans, right? Patient complains of photopsia. What is photopsia, guys? Flashes which are presenting in front of the eye. Flashes of light presenting in front of the eye is called as what? Photopsia. Patient has floaters. Patient has photopsia. Patient will be having sudden painless loss of vision. There will be sudden painless loss of vision. There will be floaters. There will be photopsia. And patient will also complain of curtain-like sensation falling in the front of the eyes, which is also called as shadow-like sensation. Curtain-like sensation or falling in front of the eye, which is called as black shadow, seen in total retinal detachment, which is the most pathognomic feature. We are discussing about retinal detachment, guys. What is the clinical features of the patient? If the retina gets detached, the patient will be having floaters, the patient will be having photopsia, patient will be having a curtain-like sensation falling in front of the eyes, which is called as what? Which is also called as shadowing, right? Which is the most pathognomic feature of what? It is the most pathognomic feature of retinal detachment. So guys, if at all a patient is suffering with retinal detachment, the instrument that is used to see how much of the retina is getting detached and all is called as indirect ophthalmoscopy. You can also go for direct ophthalmoscopy, but the best is what? Indirect ophthalmoscopy. So anyways, guys, we are discussing about what? Retinal detachment. So detachment of the retinal pigmentary epithelium from neurosensory layer is called as retinal detachment, right? Now there are three types of retinal detachment that we need to discuss. One type is called as rhegmatogenous retinal detachment, other is called as exudative, and last is called as what, guys? Tractional retinal detachment. Okay, there are three types of retinal detachment, starting with what? Rhegmatogenous retinal detachment. Who is at risk of developing this rhegmatogenous retinal detachment? Imagine, guys, I was going on a road, I had a trauma to the eye. What will happen? Due to trauma, I might develop a retinal detachment, which is called as what? Rhegmatogenous retinal detachment. Myopics are at higher risk of developing rhegmatogenous. Why, sir? Why myopics are at higher risk of developing this rhegmatogenous? First of all, why myopics are at risk of developing retinal detachment? Always remember, guys, myopics, the size of the eyeball is large. There is a condition called as axial myopia. You guys remember? What is axial myopia? Axial myopia meaning what? The axial length of the eyeball, if it is increased, that is called as axial myopia. Imagine the patient's axial length is increasing. As the axial length increases, sometimes the retina might get detached. Okay? So patients who are at risk of developing rhegmatogenous retinal detachment are what? Myopics are at risk of developing this rhegmatogenous retinal detachment. Patient who had trauma, they develop rhegmatogenous retinal detachment. Okay. So what do you see in this rhegmatogenous retinal detachment? Whenever you take an indirect ophthalmoscope and a patient who is at risk of rhegmatogenous retinal detachment, you examine his eye. In the eye, when you examine his retina, you will see some lattice degeneration occurring. Some ladder-like or lattice degeneration occurring. You might see some tear developing in the retina, which is called as what tear? It looks like a horseshoe. Hence, it is called as what tear? Horseshoe tear. It is called as what tear, guys? Horseshoe tear. Where is this horseshoe tear occurring, guys? In which quadrant of the retina is this horseshoe tear occurring? This tear is occurring in the superotemporal quadrant. Superotemporal quadrant. Right? We are talking about what? We are talking about rhegmatogenous retinal detachment. First of all, guys, I told you there are three types: rhegmatogenous, tractional and exudative. Okay? So risk factors for developing rhegmatogenous. What are the risk factors for developing rhegmatogenous retinal detachment? Risk factors for developing rhegmatogenous retinal detachment are myopes, right? Trauma, due to trauma, or aphids. They are at risk of developing what? Rhegmatogenous retinal detachment. Why myopes are at higher risk of developing? Why? Because the axial length, as the axial length increases, there is high risk to develop this retinal detachment. There is high risk to develop this retinal detachment. As the axial length is increased, there is a higher risk to develop this retinal detachment. Okay. So once the retina has been detached, you take an indirect ophthalmoscope. What will you see? You will see lattice degeneration. You will see lattice degeneration. Lateral-like degeneration inside the retina. You will see horseshoe tear. This tear inside the retina is what tear, guys? Horseshoe tear. Where is this tear occurring? In which quadrant of the retina is this tear occurring? This tear is occurring in the superior-temporal quadrant. So we were discussing about what? Rhegmatogenous retinal detachment. So in rhegmatogenous retinal detachment, what do you see? In rhegmatogenous retinal detachment, we see some features. When you do an investigation called as indirect ophthalmoscopy, you will see what? Lattice degeneration. You will see horseshoe tear. Where is the horseshoe tear occurring? It is occurring in the superior-temporal quadrant of the retina, and you might see some holes also developing. Right? That is regarding what? Rhegmatogenous retinal detachment. So, in rhegmatogenous retinal detachment, within 48 hours, you will see retinal detachment, and flashes of light could be seen, which is a pathognomic sign. What is flashes of light? That is photopsia. That's why every person who's suffering with myopia, who's having myopia, they are usually advised to have a retinal checkup. They are usually advised not to go for heavy weightlifting. Why? Because if they're axial and if they are having axial myopia, then what? Axial myopia is the most common cause of myopia. So if they are having axial myopia due to heavy weightlifting, the retina might get detached. So remember, guys, myopes are advised not to go for heavy weightlifting, regular retinal checkup, and the most important complication of myopia is what, guys? Retinal detachment. That is regarding what? That is regarding what, guys? That is regarding the rhegmatogenous retinal detachment. Now coming to what? Exudative retinal detachment. Exudative retinal detachment basically means what? The retinal detachment that is occurring secondary due to the problem or secondary due to development of some tumor of the eye. Okay? So look over here, guys. Look over here. We are discussing about exudative retinal detachment. So if the patient is having a tumor of the choroid, such as malignant melanoma of choroid, right? And that malignant melanoma of choroid spreads to the retinal pigmentary epithelium. What will happen? Imagine this is the retinal pigmentary epithelium. What will happen to the retinal pigmentary epithelium? Due to the tumor, this retinal pigmentary epithelium gets detached from the other neurosensory layers, leading to what? Retinal detachment. So basically, exudative retinal detachment meaning what? Retinal detachment that is occurring due to what? Due to a tumor which is developing on the choroid, which is called as malignant melanoma of choroid. So exudative retinal detachment, the most common cause of it is what, guys? Malignant melanoma of choroid. That leads to exudative retinal detachment, right? But in children, the most common tumor that leads to exudative retinal detachment is retinoblastoma. In children, It is retinoblastoma. In children, it is retinoblastoma. Okay. So, basically meaning exudative retinal detachment means the retinal detachment that is occurring due to some tumor of the eye. The third type of retinal detachment is called as tractional. Tractional meaning what? Tractional meaning what, guys? There's some new blood vessels being formed inside the retina that is pulling the retina away from the retinal pigmentary epithelium away from the neurosensory layers. Come on, guys, new blood vessels, when will they form? New blood vessels are usually formed whenever there is some hypoxic condition of the eye or hypoxic condition of the eye or ischemic condition of the eye, such as in CRAO, CRVO, central retinal artery occlusion, central retinal venous occlusion. What will happen, guys? In these conditions, what will happen? The blood supply to the eye is hampered. The patient will have hypoxia. Due to hypoxia, what increases? VEGF. What is VEGF? The vessel endothelial growth factor increases. That leads to formation of new blood vessels. And if these new blood vessels are formed in the retinal pigmentary epithelium, it will detach itself from the neurosensory layers, leading to what, guys? Retinal detachment, called as what? Tractional. Tractional meaning what? The retina is pulling itself away from the neurosensory layers due to formation of new blood vessels. So, tractional retinal detachment is seen in patients who are suffering with diabetes, sickle cell anemia or retinopathy of prematurity or CRA or CRVO, right? Here the patient will have a unique painless loss of vision. And how? Remember, guys, when the retina is getting detached in tractional, in which quadrant it gets detaches? It gets detaches in the superior-temporal quadrant. So, here the patient will have unique painless loss of vision, right? Painless loss of vision. And it is the most common retinal detachment. When you compare with all three, it is the most common retinal detachment. The retina detaches in which quadrant? In the superior-temporal quadrant. In the superior-temporal quadrant, right? The treatment is what, guys? How will you treat this kind of retinal detachment? If the retina is being detached, the treatment is what? You go for attachment and buckling or encerclage. If the retina is detached, you attach it back by buckling or encerclage. Buckling or encerclage could be done over here in tractional retinal detachment. Okay, that's regarding what? That's regarding tractional retinal detachment. Now, guys, diabetic retinopathy. Diabetic retinopathy meaning what? We'll start from here. Diabetic retinopathy means what? Due to long-standing diabetes, patient is having some changes in the retina that is called as diabetic retinopathy. Remember, guys, diabetes is a very bad condition. Whenever a person is suffering with diabetes, he has to take care of his blood sugar levels. It has to be under control. Diabetes is usually said as a blessing in disguise. If you control diabetes, there is no problem at all. If you control the blood sugar level, there is no problem at all. But if you don't control the blood sugar level, it will basically damage the microvascular structures in the body, such as the eyes or the kidneys. They might be damaged due to long-standing diabetes and all, right? Duration is a prognostic factor for diabetic retinopathy, but due to long-standing diabetes, long-standing uncontrolled diabetes, patient will be at risk of developing diabetic retinopathy. My question to you is, which is more dangerous? Remember, there are two types of diabetes, type 1 diabetes and type 2 diabetes. Both can develop diabetic retinopathy. But which is more dangerous, guys? Type 1 or type 2? If I am asking you which is more dangerous in context of diabetes, I am not asking in context of diabetes. I am basically asking that there is a patient who is suffering with type 1 diabetes, there is a patient who is suffering with type 2 diabetes. Okay? Both can develop diabetic retinopathy if their blood sugar levels are not controlled, right? But remember, type 1 is insulin dependent diabetes. If he doesn't take insulin, he will have symptoms due to his high blood sugar level. He will be admitted in the hospital. He'll be given the treatment for controlling the diabetes, and then it will be under control, right? Will he have a long-term uncontrolled diabetes? No. Whereas in type 2 diabetes, even though the person is suffering with diabetes, even though he is having a blood sugar level of 360, he won't be having symptoms. When he won't have symptoms, he won't go to the hospital. When he won't go to the hospital, what will happen, guys? This patient is not going to the hospital. He is asymptomatic. What will happen? The disease, now slowly this patient complains that, doctor, I am not able to see the things properly. He goes to the doctor checks his eye, and the doctor will be telling that you are having some new blood vessels developing on the retina. Yani you are having some new vascular changes occurring in the retina. He'll be asking the doctor, what new vascular changes you are talking about? Now he'll ask the patient, are you diabetic? He'll be telling, yes doctor, I am diabetic. Okay? The doctor will ask, did you check the blood sugar level regularly? He told, no sir, I checked the blood sugar level like 1 year back. It was normal. I am assuming it is normal only. You check his blood sugar level, it will be 400 something. The doctor will be telling the patient, why didn't you check your blood sugar level? The patient will tell, I did not have any symptoms of it. I did not have any symptoms of it. When you don't have any symptoms of the underlying disorder, it will be more dangerous thing. So remember guys, both type 1 and type 2, both can develop diabetic retinopathy, but it becomes dangerous in type 2 diabetes. It becomes dangerous in type 2 diabetes. Usually diabetes affect two organs. Most commonly, that microvascular structures such as the kidney and the eyes are affected by diabetes. So diabetic retinopathy means long-standing diabetes. Due to long-standing uncontrolled diabetes, patient is having some changes in the retinal arterioles. That is called as diabetic retinopathy, right? I told you which one is dangerous for it. Type 2 diabetes. Why? Because it's asymptomatic, right? Now guys, remember, India is known as the world diabetic capital. We are having 55 million diabetic patients, and kidneys and eyes are first to be damaged in diabetes, right? Duration of diabetes is a prognostic factor for diabetic retinopathy. So if a person is having diabetes from the last 5 years, it doesn't mean that he'll develop diabetic retinopathy. Okay? If the patient is having diabetes from the last 20 years to 25 years, then the risk of diabetic retinopathy is very high, right? Now guys, there are two types of diabetic retinopathy. Before going towards the earliest and the hallmark feature, okay, we'll just remember which is the earliest sign. The earliest symptom of diabetic, the earliest sign basically, it's not symptom, the earliest sign of diabetic retinopathy is microaneurysm. Dilatation of the small blood vessel is called as microaneurysm. But the hallmark feature is neovascularization. So earliest feature is microaneurysm, hallmark feature is neovascularization. Okay? You just remember these 2 points. Now coming to what? There are two types of diabetic retinopathy. One is called as proliferative diabetic retinopathy. Other is called as non-proliferative diabetic retinopathy. One is called as what guys? Proliferative diabetic retinopathy. Other is called as non-proliferative diabetic retinopathy. One is PDR. Other is NPDR. PDR is proliferative diabetic retinopathy. NPDR is non-proliferative diabetic retinopathy. Okay? Now if you go with the name, you can easily come to know what is proliferative and what is non-proliferative, right? I told you diabetic retinopathy earliest feature is microaneurysm, hallmark feature is neovascularization. If I give you this microaneurysm and neovascularization as an option, in which diabetic retinopathy you will put neovascularization? Proliferative or non-proliferative? Come on. In which diabetic retinopathy you will put this neovascularization? As you go with the name, neovascularization means new blood vessels being formed on the retina. Yani new blood vessels are proliferating. So, proliferative diabetic retinopathy is characterized by neovascularization, whereas non-proliferative is characterized by microaneurysm. So, remember guys, retinal changes. Why does retinal changes happen in diabetes? Due to glucose and its contents, retinal changes will happen. For type 1 diabetic retinopathy, for type 1 diabetes, you can check the retina every 5 years. Why? Because type 1 diabetes is usually symptomatic. They'll give you symptoms and all. For type 2 diabetes, always check the retina immediately. Every yearly they have to have a retinal checkup. Type 2 diabetes. Type 1 diabetes, every 5 years. Type 2 diabetes, every year they have to have a retinal checkup. And any type 2 diabetes presents to your clinic, you have to post him immediately for retinoscopy. Okay. The basic pathology over here is what? In diabetes, remember diabetes is a thromboembolic disease. Whenever the patient is having diabetes, there is thromboembolism that leads to formation of hypoxia. That hypoxia increases the VEGF. That hypoxia increases the VEGF. What is VEGF? Vascular endothelial growth factor. If the VEGF is increased, what will happen to the blood vessels? New blood vessels will form. Okay? So remember, the basic pathology is diabetes have a lot of thromboembolic activities that leads to hypoxia, VEGF, and new blood vessels being formed. New blood vessels being formed. Right? Now, remember guys, microaneurysm is seen in non-proliferative, whereas in proliferative you see what? You will see neovascularization, new blood vessels formed in the retina. Right? So I told you there are two types of diabetic retinopathy. What are the two stages or two types? One is called as non-proliferative, other is called as proliferative diabetic retinopathy. Proliferative diabetic retinopathy is characterized by neovascularization. Right? The hallmark feature of proliferative diabetic retinopathy is new blood vessels being formed on the retina. Right? Now, as these new blood vessels are forming, first the new blood vessels, where will it form, guys? First, the new blood vessels will form on the optic disc. On the optic disc, which is called as NVD. That is called as NVD. NVD means what? Neovascularization of the optic disc. Then the neovascularization occurs on the NVE. NVE means neovascularization elsewhere. Then there is neovascularization of the iris, which is also called as rubeosus iriditis. Okay? First the new blood vessels are formed on the optic disc, then elsewhere, and then it is on the iris. Right? So, if it is formed in the iris, guys, if new blood vessels are formed in the iris, what will happen? The iris becomes heavy and shaky. That iris sticks to the lens, leading to what? Leading to closure of the posterior chamber. That leads to pressure is increased, iris bombi, and angle closure glaucoma. Such a glaucoma that is occurring due to new blood vessels being formed is called as neovascular glaucoma. Right? So remember guys, first the new blood vessels are formed on the optic disc, next is on the elsewhere in the eye, last it forms on the iris, which is called as rubeosus iriditis. Rubeosus iriditis. Right? That leads to the neovascular glaucoma. That leads to neovascular glaucoma. Coming to the next, which is called as non-proliferative. Non-proliferative meaning what? It is not proliferating, it is only just staying at one part. So it is characterized by what? Non-proliferative, it is characterized by microaneurysm. It is characterized by non-proliferative, it is characterized by microaneurysm. Right? Microaneurysm. But is just microaneurysm seen over here? Guys, look over here. What is meant by aneurysm? Aneurysm is what, guys? Dilatation of the blood vessel. Small dilatation of the blood vessel is called as aneurysm. From a weaker point of the blood is called as aneurysm. Right? Due to this microaneurysm, sometimes the blood vessel rupture, leading to some hemorrhage inside the retina. What is that hemorrhage called as? In non-proliferative, you might see some hemorrhage, which is called as what? Dot and blot hemorrhage. Which is called as what, guys? Dot and blot hemorrhage. You will see cotton wool spots or soft exudates. You will see cotton wool spots or soft exudates. Cotton wool spots or soft exudates. Okay? Cotton wool spots are just not seen in diabetes. They are seen in some more conditions also. Okay? you will see cotton wool spots or soft exudates. Now, due to some hemorrhage inside the retina, this dot and blot hemorrhage, if that blood touches the macula, the patient will develop what? Macular edema. The patient will develop what, guys? Macular edema. Macular edema is seen, right? So, why is the patient losing vision in proliferative, in non-proliferative? Remember, guys, in proliferative diabetic retinopathy, the patient loses his vision due to some problems like vitreous hemorrhage, neovascular glaucoma, and other problems. But in non-proliferative, it is characterized by microaneurysm. Why does the patient loses his vision? Due to microaneurysm, there might be some due to this microaneurysm, there might be some blood vessels which might get rupture, and that ruptured blood vessel, if that blood touches the macula, the patient lands up into macular edema. Due to macular edema, the patient loses his vision in non-proliferative diabetic retinopathy. In non-proliferative diabetic retinopathy. Right, guys? So, right there, right. The reason why the patient loses his vision in proliferative diabetic retinopathy, the patient loses his vision. Remember, loss of vision in proliferative diabetic retinopathy is what? It is the neovascular glaucoma. It is the neovascular glaucoma. It is vitreous hemorrhage, or it could be tractional retinal detachment. Whereas in non-proliferative diabetic retinopathy, there is no new blood vessels being formed. What will you see? The patient will have loss of vision due to what? Due to macular edema. Due to macular edema. Right? So now, guys, I told you there is some cotton wool spots seen. What are these cotton wool spots? Cotton wool spots are collection of exoplasmic debris. Okay? Cotton wool spots are collection of exoplasmic debris that could be seen in proliferative diabetic retinopathy, and they could be seen in other conditions also. Remember, these cotton wool spots are also called as soft exudates. Right? There is a difference between hard and soft exudates. You might also see hard exudates in diabetic retinopathy. In this diabetic retinopathy, you might also see some hard exudates. In non-proliferative, you are seeing many features, guys. In proliferative, it is characterized only by neovascularization. In non-proliferative, you will see microaneurysm, dot and blot hemorrhage, macular edema. You will see what, guys? Cotton wool spots. You will see hard exudates. You will see hard exudates. These are the features of what? These are the features of non-proliferative diabetic retinopathy. Okay. So guys, remember, we are discussing about proliferative and non-proliferative diabetic retinopathy. Proliferative diabetic retinopathy is characterized by new blood vessel formation. That is called as neovascularization. Whereas non-proliferative is characterized by microaneurysm. Due to this microaneurysm might rupture, leading to what? Dot and blot hemorrhages. That hemorrhage can touch the macula. Patient will land up into what? Macular edema, right? Macular edema, that's why the patient loses his vision. You might see hard exudates or you might see soft exudates. Hard exudates are cholesterol leak, and soft exudates are collection of exoplasmic debris. Collection of exoplasmic debris. So in non-proliferative, you might see hard exudates as well as soft exudates. Okay? Hard exudates are what? Cholesterol leak. Soft exudates are what? Cotton wool spots, which are collection of exoplasmic debris. Okay? Apart from that, what else we need to remember over here is what? What else we need to remember is, in non-proliferative, what are the features that you see? You will see microaneurysm. We have already discussed, guys. You will see microaneurysm. You will see dot and blot hemorrhage. You will see hard exudate. You will see soft exudate, right? Microaneurysm, soft exudate, cotton wool spots, hard exudate, dot and blot hemorrhages could be seen over here, right? Dot and blot, it's not dark blot, it's dot and blot hemorrhages. Retinal hemorrhage could be seen, retinal edema could be seen, or macular edema could be seen. These are the features of non-proliferative diabetic retinopathy, right? Now, guys, what are the clinical features of a patient who is suffering with diabetic retinopathy? What are the clinical features, guys? Obviously, diabetic retinopathy means the patient is having a loss of vision. How is the loss of vision? Is it painful loss of vision or is it painless loss of vision? Right guys. So what are the clinical features of the patient who is suffering with diabetic retinopathy? The patient will be having sudden painless loss of vision. Okay, that will be in the last stage. Initial stage, the patient complains of what? The patient complains of black spot floating in front of his eyes. That is called as what? Floaters. That was also seen in what? Retinal detachment. The patient complains of floaters. That is the main complaint. Why is the patient complaining of floaters? Why? Because in diabetic retinopathy, patient will have vitreous hemorrhage. Due to that, he will complain of floaters. Is vitreous hemorrhage just seen in diabetes? No, sir. Vitreous hemorrhage is seen in some other conditions also. The most common cause of vitreous hemorrhage is obviously diabetes. But if the question is asking you what is the most common cause of vitreous hemorrhage in young adults, it is what, guys? It is trauma. If the question is asking you what is the recurrent cause or what is the second most common cause of vitreous hemorrhage in young patients, then it is Eales disease. What is Eales disease? It is also called as periphlebitis retinae. Meaning what? Post TB infection patient develops this retinal changes. That is called as Eales disease. So just write over there, guys. Clinical features of the patient who is suffering with diabetic retinopathy. The patient will be having sudden, painful or painless, guys? Sudden, painless loss of vision. Apart from sudden painless loss of vision, what are the other features of the patient? Patient will also have floaters. Floaters is a complaint of the patient. Why is the complaint of the patient floaters? Why? Because the patient has vitreous hemorrhage. Vitreous hemorrhage, right? Now, the common cause of vitreous hemorrhage is diabetic retinopathy. Right? The common cause of vitreous hemorrhage in young adults, it is trauma. Next, then the second most common cause of vitreous hemorrhage in young adults, second most common is what, guys? It is Eales disease. What disease? Eales disease, which is also called as what? Periphlebitis retinae, which is also called as periphlebitis retinae. Periphlebitis retinae. So imagine, guys, the patient is having what? Eales disease and all, right? Eales disease and all. How will you manage? Eales disease patient complains of what? The patient will be having spontaneous vitreous hemorrhage, spontaneous or recurrent vitreous hemorrhage. Recurrent vitreous hemorrhage, then the diagnosis is Eales disease. For diagnosing diabetic retinopathy, there is a chart which is done, which is called as ETDRS chart, Early Treatment Diabetic Retinopathy Study Chart. Okay? But guys, remember, if the patient is having Eales disease and developing diabetic retinopathy, you go for ETDRS. And what is the management that you give? Remember, Eales disease or periphlebitis retinae is secondary due to tubercular infection of the eye. So treatment is what? Giving anti-tubercular drugs to the patient and giving steroids. Giving anti-tubercular drugs and steroids. If the patient develops vitreous hemorrhage, then what will you do? You give bed rest to the patient so that the hemorrhage absorbs. Or if there is a large hemorrhage, then you have to go for vitrectomy. You have to go for vitrectomy through the pars plana. That is called as pars plana vitrectomy. That is called as pars plana vitrectomy. So once again, guys, if diabetic retinopathy patient who is suffering, if diabetic retinopathy patient develops vitreous hemorrhage, that is common, guys. But if the patient is developing recurrent vitreous hemorrhage, then the cause is periphlebitis retinae. Treatment of it is what? Anti-tubercular drugs and steroids. Why? Because periphlebitis retinae is secondary due to tubercular infection. Eales disease commonly occurs due to tubercular infection. Due to tubercular infection. Okay, that's regarding what, guys? That is regarding the diabetic retinopathy. That is regarding diabetic retinopathy. Okay, now guys, what is the treatment for diabetic retinopathy? Treatment of diabetic retinopathy, which is, remember, treatment of non-proliferative we have discussed. Non-proliferative we have discussed. Okay, we are discussing about what? Treatment of proliferative diabetic retinopathy. Proliferative is characterized by new blood vessels forming. For new blood vessels forming, we have to coagulate the blood vessels. The immediate answer for neovascularization is what? Photocoagulation. Will you photocoagulate only one part of the eye? No, you will photocoagulate almost all part of the eye. That is called as, or almost all part of the retina. That is called as what? Pan-retinal photocoagulation. Pan-retinal photocoagulation. So remember, photocoagulation is you take a laser and you coagulate the blood vessel. It's a type of laser surgery where we use intense beam of laser to burn the area of the retina and abnormal blood vessels which are being formed, right? The treatment of choice is what? Pan-retinal photocoagulation. As we are damaging the periphery, there will be loss of visual field. As we are photocoagulating the blood vessels on the periphery and all, there might be damage to the visual field. And which visual field can be damaged? It is the superior-temporal quadrant, or it is basically the temporal quadrant. Just cut it and repeat it once again. Which visual field is damaged, guys? The visual field that is damaged over here is what? The temporal field. The temporal field could be damaged over here, right? So remember, guys, the treatment of choice for diabetic retinopathy is what, guys? Photocoagulation. Why? Because diabetic retinopathy proliferative is characterized by what? It is characterized by neovascularization. And whenever there is a term neovascularization, the immediate answer should be what? Photocoagulation. What photocoagulation? Pan-retinal photocoagulation. Pan-retinal photocoagulation, right? So remember, guys, the laser that is used in pan-retinal photocoagulation, it is Nd:YAG. No, it is double frequency Nd:YAG laser. Nd:YAG was a colorless laser. Double frequency Nd:YAG laser is a green color laser having a frequency of 532. What was the frequency of Nd:YAG laser? 1064. Okay, so double frequency Nd:YAG laser, it's a green laser with a wavelength of 532, and it is the laser of choice for management of what? Management of diabetic retinopathy. Okay, all the arteries inside the body will undergo what? Constriction. In hypertensive retinopathy also there is what? Arteriolar constriction. The diameter of the artery is very much narrowed. When you remember, guys, we are discussing about what? Hypertensive retinopathy. Hypertensive retinopathy is due to long-standing hypertension. Some changes in the retina are seen. That is called as hypertensive retinopathy. The earliest feature is constriction of the arteries or the arterioles. When you compare the normal arteries to vein diameter, it is 2:3. Where the arterial diameter is 2, vein diameter will be 3. But in hypertensive retinopathy, this diameter changes to 1:3. The arterial diameter constricts very much, and the ratio becomes 1:3 over here. So in hypertensive retinopathy, what will you see? In hypertensive retinopathy, there are some signs that you see. First sign is called as gun sign. Second is called as Salus sign. And third is called as Bonnet sign. Gun sign. Gun sign meaning what? Narrowing of the veins where the arteries, at the atriovenous crossing, there is narrowing of the veins. That is called as gun sign. Salus sign is deflection of the veins, the vein getting deflected. That is called as Salus sign. Next is called as Bonnet sign. Bonnet sign is banking of the veins due to arterial compression. So basically remember, guys, there are 3 signs of hypertensive retinopathy. The first sign is what? The first sign is called as gun sign. What is gun sign? Gun sign is nothing but narrowing of the vein where the arteries, basically narrowing of the vein at the atriovenous crossing. Narrowing of the vein at the AV crossing. That is called as gun sign. Next is called as Salus sign. What is Salus sign? A deflection of the vein is called as Salus sign. Bonnet sign is banking of the veins due to arterial compression is called as Bonnet sign. These are the signs of what retinopathy? Hypertensive retinopathy. Hypertensive retinopathy. And again, once again guys, as the arteries are getting constricted, what will happen? These arteries will get constricted, the pressure inside the artery builds up, and after some time the artery might rupture, leading to what? Leading to hemorrhage. The hemorrhage that you see over here is flame shape or striate hemorrhage. You will see flame shaped or and striate hemorrhage. Flame shape and striate hemorrhage could be seen over here, right? So now guys, remember we know that what is, remember we have discussed in hypertensive retinopathy what is happening to the arteries, what is happening to the arteries and all. Gun sign, Salus sign and Bonnet sign is seen. In the initial stages, the arteries look like a copper wire, okay? But as and as the disease progresses, they look like a silver wire, ultimately leading to what? Papillary edema. Papillary edema is what guys? Edema of the optic disc, okay? So, as the hypertensive retinopathy patients are not treated, in the initial stage, they will have copper wiring of the arteries followed by silver wiring and ultimately leading to what? Final stage is papillary edema. Final stage is papillary edema, right? So, remember in hypertensive retinopathy, you will see cotton wool spots, you will see narrowing of the arteries, right? You will see copper wiring, blot hemorrhages, nicking of the arteries and exudates, okay? So, these are the features of what retinopathy? Hypertensive retinopathy. So, remember guys, why is the patient losing his vision in hypertensive retinopathy? Why is the patient losing his vision in hypertensive retinopathy guys? As the patient is having long-standing hypertension, the arteries become narrow, you see all the signs and all. We are talking about hypertensive retinopathy. Why is the patient losing his vision in hypertensive retinopathy? We know what is the changes that are occurring in the arteries and all, right? We know that there is copper wiring, silver wiring and papillary edema, right? But initially it usually starts with what? Gun sign, Salus sign and Bonnet sign. Now guys, remember, why is the patient losing his vision? Why? Because as the arteries is getting narrowed, the pressure inside the artery increases. It increases to such an extent that the artery will rupture, leading to hemorrhage. Okay, leading to what? Leading to hemorrhage. And if there is some blood touching the edema, some blood touching the macula, if some blood goes and touches the macula, what will happen to the macula? The macula gets edematous. That is called as macular edema. The most common reason for the patient to lose his vision in hypertensive retinopathy is macular edema. Macular edema. While in diabetic it was vitreous hemorrhage, right? So look over here. How will you manage hypertensive retinopathy? It's very simple guys. You check the BP and manage the BP. The retinopathy changes can be easily reversed back to its a normal thing, right? So the management of hypertensive retinopathy is check the BP and manage or control the BP by giving some antihypertensive medications.